This voice-over PowerPoint will include the two lectures that were planned on superficial, cutaneous, and subcutaneous fungal infections. And these agents that we're discussing today, they were grouped together because they have some similarities in their manifestations and how they cause infection. Let's start with the superficial fungal infections. The agents we're going to discuss today are grouped based on where they cause infection or where their manifestations are seen, how deep the infection goes. So we'll be discussing superficial, cutaneous, and subcutaneous mycoses today. So when I'm saying mycoses, M-Y-C-O-S-E-S, that's plural for mycosis, which is singular. So the first part, we'll talk about the superficial mycosis or agents that cause superficial mycosis. In this case, the infection is seen or the agents grow above the surface of the skin and the hair. They do not have the ability to produce keratinase, so they do not really invade deeper. The superficial fungal infections we'll be discussing are Tinea versicolor, Tinea nigra, white piedra, and black piedra. And as I said on the previous slide, these are the agents that cause these infections are they grow on the surface of the skin and the hair, so they do not have keratinase. They cannot go deeper than that, and they don't have that much of an inflammatory response. They don't cause much of an inflammatory response, and so this means there's barely any itching, doesn't hurt that much, and so it's mostly a cosmetic infection that people sometimes tend to ignore. As you'll see with a lot of the infections we will be discussing today, people tend to ignore them. They're not that painful. And so lots of times patients are not aware of what they have, not aware of the infection. Starting with the tinea versicolor, which is also called pityriasis versicolor. So in this case, this is chronic infection. This is superficial infection of the stratum corneum, and the characteristic manifestation are these flattened, discolored lesions of the skin. So some of them you can notice here that they have variable sizes. That's because some of them are small, but then they can coalesce and merge together to form bigger lesions. Um, just like a lot of the infections we're discussing today, we have barely any itching or irritation. However, the skin might slough off because it might be scaly. You would have like very fine scales. So the lesions are discolored. Sometimes they are hyperpigmented and sometimes they are hypopigmented. So their color really depends on various environmental conditions and on the patient status. And so sometimes the reason why you see them looking pale in color in some people is that sometimes during the beach season, people are exposed to sun, and so what happens is that the skin acquires deep tan. However, the discolored lesion where you have the tinea versicolor doesn't acquire this coloration, so it becomes paler in color compared to the surrounding skin during the summertime in lots of people. And then during the winter time, sometimes the reverse happens. And you will see that these lesions sometimes, if people take, for example, like a warm shower, due to the warmth of the water, the coloration also changes, and so we have some variable coloration of these lesions. So again, these are flattened lesions, they are macular, that is, and they are well demarcated, and the severity of the disease is sometimes variable. Most of the time, to bear in mind that there's barely any irritation in the patients. And now, where do we see these lesions? They in adults, you mostly see it on the trunk region, as well as the shoulders and the arms, and you less often see it on the upper thighs, neck, and face. Uh, However, this is not very true in children. In children, the face is more commonly seen to have these lesions than in adults. So what causes tinea versicolor? The agents are the Malassezia species, most commonly Malassezia globosa, but other Malassezia species can cause this as well. These are actually part of our normal flora. They are dimorphic yeast. Most commonly, as part of our normal flora, they are in the yeast form. And when they switch to the mycelial form, this is the pathologic form. Why they switch is poorly understood. We don't really know why. There might be a genetic element to it. It might be due to environmental conditions such as humidity or warmth, or um, possibly the immune status differences or changes. Um, Under the microscope, this is what the wet mount looks like, and you'll see the yeast and you'll see the hyphal elements. This is what's called the spaghetti and meatballs characteristic manifestation. So I'm sorry about this, but I will be ruining a couple of food items for you today, such as spaghetti and meatballs and cauliflower later on in the lecture. Um, and just again, to sum this up, these are part of our normal flora. We don't usually need to worry about them. And if they switch to mycelial form, they would cause tinea versicolor. Tinea versicolor, colloquially in Arabic, is sometimes referred to as عطيشة. Tinea versicolor is seen worldwide. It's more common in warm areas, in humid climates. The agents, the Malassezia, these are lipophilic agents. So they like oil, basically. They like oily skin. And who has oily skin? It's, of course, young adults. So it's mostly disease of young adults, but you might see it in childhood or old age. Despite the fact that these two groups have less oily skin, less sebum, but you might still see it in them. Diagnosis, we have a very characteristic uh, manifestation, which is these discolored lesions. If you expose these lesions to woods light, you will see yellow or greenish yellow fluorescence. So again, just to remind you from our previous lecture together, woods light is UV light that is emitted at 366 nanometers of wavelength, and some dermatologic agents will fluoresce when exposed to this light, and this is one of them. In the lab, like I said on the previous slide, if you take the wet mount, you examine it, you'll see the spaghetti with meatballs manifestation or characteristic, and you'll see these hyphae, these yeast cell clusters. Culture is difficult, and our typical medium, which is, if you remember, was the Saburo, but if you add olive oil to it or oil to the Saburo, you would enhance the possibility of culturing the organism because it is lipophilic. As for treatment, you can use topical agents and you can use oral agents if you have severe or non-responding cases. However, despite treatment, recurrence is rather common. But what you would tell the person is to continuously control it and prevent it by trying, for example, to shower with certain shampoos that contain some of these agents uh, that might help curb the infection or control it. Malassezia species are also associated with other diseases such as seborrheic dermatitis, which is a spectrum of diseases. At the very least, it looks like dandruff. Dandruff is not just associated with Malassezia, though. There are some vitamin deficiencies that can result in dandruff. Um, it might be more severe. You might see erythematous uh, lesions, like you're seeing here. So, skin irritation and reddishness of the skin, and might affect the scalp, the face, or the trunk. So why does this happen? Um, so what we think happens is because Malassezia species, they like oil, like we said on the earlier slide, in the previous slide, they will metabolize lipids and oils. And so one of the byproducts is oleic acid, for example, and that might go deeper within the skin and can cause sort of an inflammatory reaction that results in seborrheic dermatitis. Now, the link is not 100% confirmed. So we're not 100% sure of this because remember that malassezia are part of our normal flora. What does sort of uh, help establish this correlation or make it seem more legitimate is that in some cases, people who have taken oral antifungal agents, the conditions seem to have been alleviated. So this kind of supports the notion that uh, seborrheic dermatitis has malassezia as an underlying cause. Rarely, what you might see is opportunistic fungemia. So, all of the conditions we're discussing today, or all of the agents we're going to discuss today, they are not associated with deep infections or systemic infections. However, all bets are off, of course, are in the immunocompromised. Or somebody who has a weak immune system. So, opportunistic fungemia with malassezia might occur. It's rare, it might happen in infants, for example. As for folliculitis, this is when infection goes deeper within the hair follicle, and so what you would see is an acne-like presentation due to malassezia infection. Continuing with the superficial. This is another superficial infection. So again, it's one of these diseases that do not hurt that much or do not itch that much. So people don't worry much about them. In this case, what you see is this chronic infection of the stratum corneum. We see well demarcated flattened lesions that are within the skin. The coloration is brown to black, and that's because the agents that cause them, or the agent that causes them, is actually a dematteous pigmented agent. This is why we see this coloration. They do not itch, and they do not have any scales on them. They're more commonly seen on the palms and less so on the soles. If they happen on the palms, this is called Tinea nigra palmaris, and if it happens on the sole of the foot, it's called Tinea nigra plantaris. So these look like actually like somebody worked with silver nitrate and they had a stain there, so they don't look like something to worry about that much. Um, so they might occur in other skin surfaces, but they're mostly seen on the palms. The agent behind the Tinea nigra is Hortaea wernickeyi. This is a dimorphic fungus, and it's seen in environmental samples like soil, wood, compost. So you can kind of make the link between uh, seeing these lesions on the hands, on the palms, because people might touch um, these types of samples like soil and wood, um, or the foot. Specifically, if people decide to walk barefoot in the woods, that might happen. It has also been isolated from salt waters, and so people, well, at the beach, they are also possibly exposed to this agent. And what we think happens is we have trauma that happens in that area that allows for lodging of the organism, the Hortaea wernickeyi, in that region. After the person is exposed, the incubation period is typically 2 to 7 weeks, but people have um, underwent experimental inoculation. Yeah, believe it or not, some people agreed to have traumatic experimental inoculation, and the incubation periods were variable, and some incubation periods lasted as long as 20 years before they started seeing these stain-like uh, uh, brown lesions. So what happens if you take a wet mount and decide to examine it? What you will see are these rather pigmented septate hyphal agents. So see septate hyphal agents or hyphal filaments, and you'll also see some budding yeast as well. So again, Hortaea wernickeyi is the agent behind this. It is a dimorphic fungus, and this is why we're seeing both yeast and um, hyphal elements. Where is the disease seen? This is a rare disease. It's more commonly seen in tropical climates because this is where the fungal agent prefers to be. Um, it seems to be more common, epidemiologically speaking, in females and in younger people than in males and older people. How is it diagnosed? It's Clinical presentation, you can highly rely on the clinical presentation, but you have to rule out malignant melanoma. And so to do this, of course, you would need a wet mount. And if you examine the wet mount and you see the characteristic fungal agent, you'll know that it is tinea nigra. A culture can also be performed to support your diagnosis. As for treatment, you can use agents that help you in drying out the skin and sloughing off the skin. So skin desquamation agents like salicylic acid can be applied topically, but you can also use antifungal agents for treatment. And in that case, it's also topical treatment, mostly topical treatment. The next two types of superficial mycoses are highly similar in their manifestation. They are, or manifestations, and they are the white piedra and the black piedra. So starting with the white piedra refers to the presence of soft, whitish or off-white nodules on the hair shaft. So these are actually just loose hyphal aggregates. So these nodules are loose, so you can actually detach them from the hair shaft. It's mostly seen on pubic, axillary, and facial hair, but you might see it on scalp hair as well, but it's more common on pubic, axillary, and facial hair. Uh, so these nodules, they don't cause much of an irritation to the person who has the infection, and so because it's asymptomatic, people might ignore them. And if they do ignore them and these hyphal aggregates stay there on the hair shaft for a prolonged period of time, the cuticle of the hair might be penetrated, resulting in hair breakage. The agents behind white piedra are the Trichosporin species, most commonly Trichosporin acai. These are dimorphic fungi. So if you take the nodule, you crush it, you examine it under the microscope, what you will see are these irregularly shaped septate hyphae, and these like cells. These are hyaline, so they are not pigmented. And sometimes you might see arthrospores. What you're seeing here is basically this is the hair and the loose hyphal aggregate, the white or off-white nodule, and then this is a closer examination of these elements that could help you out in the diagnosis. So these agents are part of our normal flora. You'll see them in the mouth, skin, and nail normal flora, but they have also been isolated from samples from the soil, from water, from other environmental samples, as well as from certain animals. So they're part of our normal flora, so we don't really know why they switch to pathogenic form and cause infection. We also don't know how it's really transmitted. Is there person-to-person transmission or not? This has not been completely understood so far, or we're not 100% sure of these aspects of infection. White piedra is common in temperate and semi-tropical climates, and there is no age predisposition. It seems to affect all age groups. When you're trying to diagnose such an infection, you can rely on the clinical presentation, but in that case, you have to rule out the presence of lice nets, Bayd al-Amin in Arabic, as well as trichomycosis axillaris, whereby you see beigeish or off-white nodules, mostly on axillary hair. In that case, it's caused by bacterial agents, and so you'd have to rely on the wet mount and culture to rule out these agents. So crushed nodules, examine them, or you can culture the elements. As for treatment, the hair has to be shaved or cut, and you can use topical and oral agents, but bear in mind that the relapse rate is quite high with these agents. As for black piedra, which is the last type of superficial mycosis we'll be discussing, this is similar to white piedra, but there are some differences. In this case, instead of the nodules being soft and white and loosely attached to the hair, in this case, these are uh, dark blackish or brownish nodules, and these are firmly attached to the hair shaft. They're not as loose or as soft as the white piedra, and they are blackish. And they're mainly seen on the scalp hair, unlike white piedra, which is less commonly seen on scalp hair. And so these are not usually seen, or the black piedra is not usually seen on other areas of the body. So it's mostly the scalp hair. But similar to the white piedra, the disease is asymptomatic, and so people might ignore it. If the infection is left uncontrolled, then eventually it might lead to penetration of the hair cuticle, and so the hair would break. This is what a nodule looks like um, on the hair. The agent behind black piedra is Piedria horti, and this is a mold species. It's found in soil in tropical climates, and this is what a nodule would look like under the microscope. And then if you crush it and examine it, what's typical to be seen are these asci, so these asci will contain ascospores. If you remember from our introductory lecture, I showed you a picture of the asci with molds, and those look more villous, like if you remember, but this is actually more round-like with this type of species. So always keep in mind that you always have these variabilities in what things look like or the types of manifestations that you might see. So based on the ecology of where you see this agent, the mold that causes black piedra, um, this is why the disease is more common in tropical climates. And again, there is no specific age predisposition. Diagnosis relies on the clinical presentation, on seeing these nodules, but in this case, you have to rule out a disease called monolithics, and this is a genetic disease. There's a genetic aberration in genes that encode certain types of keratin, and so this results in nodular hair, so you have to rule that out. Uh, what you can do to do so is take the nodules, crush them under the microscope, examine them, so wet mount, and you can also perform culture. Treatment is similar to white piedra. So again, hair shaving and cutting, you can use topical and oral agents. However, one thing to point out here is that a specific agent called terbinafine seems to be effective against black piedra, and that's because this agent accumulates in keratinized structures as you learn more about it later on in the course. But again, the relapse rate is high. Take a moment to think about this question. So Hortei werneckii, this is the amorphic fungus that we talked about previously in this lecture today. So which of the following is correct regarding this agent? Does it A, cause Tinea nigra palmaris but not plantaris? B, it does not produce keratinase? C, it causes severe inflammatory reaction in somebody who is infected? Or D, cannot survive in the environment? Right, so if you were paying close attention, Hortei werneckii, this is the agent that causes Tinea nigra. And well, tinea nigra can appear on the sole of the foot or on the palms, and so it does cause both of these manifestations, both tinea nigra palmaris and plantaris. So this option is not correct. Can it survive in the environment? Yes, it is present in environmental samples. This is where we get the infection from, and does not cause severe inflammatory reaction. All of the agents that cause superficial infection do not cause severe inflammation. So the correct answer is that this agent does not produce keratinase, just like the rest of the superficial fungal agents we have discussed today. So the correct answer is B. Cutaneous mycosis is sometimes grouped with superficial mycosis, so lots of people will group these two together. However, we can basically separate between the two groups due to some differences that I will mention as we go along. Cutaneous mycosis can be caused by Candida, but people mostly discuss that they're metaphytes when they're referring to specifically to cutaneous mycosis. So these agents can produce keratinase, but they cannot seem to live in deeper tissues despite having keratinase. So they're not really invasive. However, their inflammation extends deeper. So you'll see that they live in keratinized tissues. They can infect the skin, the hair, and the nails, but they don't seem to go deeper. And the reason for this is that we think there is an inhibitory factor in the serum, which goes into interstitial tissues. And so what happens is that this inhibitory factor, which is very likely to be transferrin, so we think dermatophytes like iron, they need iron for their growth, and so we think transferrin well chelates iron. So what happens is these agents are deprived of iron, so the infection cannot go deeper. So the infection is constrained basically to the skin, to the hair, to the nails, but their metabolites, their byproducts, they can go deeper, and so inflammation might extend deeper into the epidermal and the dermal layers, but not the growth of the fungus itself. So the fungus itself rarely ever goes deeper. We think mostly because there is inhibition of growth due to some serum inhibitory factor, which is more likely to be transferrin. Right? So cutaneous mycoses, like I said on the previous slide, they can be caused by the dermatophytes. There are three genera of these: epidermophyton, microsporum, and trichophyton. And then we'll see the various types of manifestations as we go along. The other fungal organisms that can cause cutaneous infections are Candida, but we will not discuss Candida in this session. We'll talk more about Candida in a different section of the course where you'll be discussing systemic mycoses, but Candida, bear in mind that it can also cause a cutaneous non-systemic, that is, infection as well. So the dermatophytes are grouped based on where you see them mostly, so their primary habitat. Some of them are mostly seen in humans, and these are referred to as anthropophilic. Some of them are found in animals, that's their habitat. These are zoophilic, and some of them are found in soil, so these are geophilic. Of course, we do not expect you to remember all of the various species. There's about 40 of them, or about 30 that cause infection in humans, but we will be mentioning some of the relevant ones as we describe the various manifestations. As a sum up the things we've mentioned on previous slides, so these dermatophytes, they can produce keratinase, but they do not invade deeper than the skin, hair, and nails because of the presence of serum, which we think contains the inhibitory factor, which is very likely transferrin, which chelates iron that's thought to be required for the dermatophytes. There are about 40 species, and 30 of these have been to date described as agents that cause disease in humans. There are three genera: Epidermophyton, Microsporum, and Trichophyton. So mind you, Trichophyton, not Trichosporin, which we've seen in the superficial mycosis section. The Epidermophyton, based on its name, as you can tell, it seems to mostly affect the skin, rarely the nails, and you'll never ever see a hair infection, which is called tinea capitis. You'll never see a hair infection caused by Epidermophyton. As for Microsporum, it seems to have an equal appetite for skin and hair, but it less often affects the nails. Trichophyton can affect skin, hair, and nails, all three structures. Once you acquire the organism, the incubation period is less than a month. It's about 1 to 3 weeks. And here, as we've described earlier, there is just an infection of the skin, hair, and nails. There's an infection of the stratum corneum. There's growth within and around keratinized hair, nail plate, and the nail bed, with no deeper infection because of the serum inhibitory factor, which is very likely to be transferred. However, despite the fact that invasion by the organism doesn't go deeper, the inflammation does. And in some cases, you'll see the inflammation affecting deeper epidermal and dermal layers. And we think this happens because of inflammatory reactions towards metabolic byproducts of these dermatophytes. So the dermatophytes, their metabolism produces products that can go deeper, and this is why inflammation might happen there. As you may expect, the intensity of inflammatory reactions, the least is towards the anthropophilic species. So these are species that are adapted to us because we are their primary habitat, and our immune systems are very likely have previously been exposed to them, and so uh, the least inflammatory reactions are towards the anthropophilic species. Next in line would be the zoophilic ones, and the most distant from us are the geophilic dermatophytes, and so the intensity of inflammatory reactions are expected to be more intense with the geophilic ones. There are various types of manifestations of dermatophytosis, starting off with Tinea corporis, which is referred to as the body ringworm, and you'll see why we call this a ringworm in a little bit. So all these infections are referred to as a ringworm. You'll see where this comes from. Usually Tinea corporis happens on glabrous skin, which is the relatively hairless skin, and what you will see is we have these plaques, these raised plaques, and then the central area will clear out, so you end up with a border, and then the borders keep growing outwards while the central area will keep on clearing. So this is referred to as Tinea cercinata. This is the classic type, and in Latin, cercinet means circular. This is where the name comes from. And as for the tinea part, so the ringworm part, that's because people see these borders growing out, so they associated this with a mobile organism, likely a ringworm. This is how they acquired their name, tinea or ringworm. So Tinea corporis, just like with most of these dermatophytes, we see them in with the humidity. They are associated with dampness, with humidity, and Tinea corporis is mostly seen in hot and humid climates. But dermatophytes overall, they are highly associated with dampness, and this is why we always tell people to keep their skin dry, dry-ish, that is, and to make sure that their nails are dry, to make sure that their hair is dry, because these agents, the dermatophytes, they really like dampness. Right. So the Tinea cercinata, this classic type of Tinea corporis, this is how these ringworms got their name. And these borders that I just described, these might have scales, they might have pimples on them, they might have pustules or blisters. They are variable manifestations of this, but this is the classic type. As for Tinea imbricata, this is a specific type of Tinea corporis, the body ringworm, and it's associated with an anthropophilic organism, which is Trichophyton coencentricum. And here what you see are overlapping circles. So these concentric circles, these overlapping circles, um, they are associated with this organism, but they're also associated with genetic predisposition, which has not been completely uncovered yet. Tinea corporis also includes other types of manifestations, such as tinea pedis, which is the very famous athlete's foot. It's associated with athletes who share shower stalls and do not really dry out their feet very well. This is the foot ringworm, and it will involve the soles and the toe webs. And you'll see that in some people, if this is not well taken care of, you might easily spread it to the toenails as well, and we'll talk more about this in a little bit. Tinea manium or Tinea manus, this is the hand ringworm, and here we see this affects the palms and the finger webs. And again, if Tinea manium is not watched out for, the same agents, because some of these agents have appetites for nails, we might end up with a nail infection on top of the Tinea manium. Now again, both of these are associated with dampness, humidity, and not uh, drying out your hands. Lots of times people will wash dishes and will not dry their hands out very well, or they use damp gloves consistently. And so all of these are predisposing conditions for these types of body ringworm. And one thing I would like to mention as well is that sometimes People would wear tight shoes, and tight shoes might lead to sweating of the feet. If that is not taken care of as well, all of these are predisposing factors for dermatophytes and for dermatophytic infections. Tinea corporis might also manifest as jock itch, which is called tinea cruris as well. In this case, the affected areas are the groin. It doesn't affect the genitalia, it affects the groin sides, and it might also affect the perineum, which is the region between the anus and the genitalia, and might also affect the perianal region. It's more common in men than in women. Tinea fasciae or tinea fasciale. In that case, we have infection of the skin of the face and specifically the glabrous skin, so the relatively hairless uh, skin. One thing I'd like to point out is that a candida infection might cause something similar to tinea cruris, so bear that in mind as well. The second type of dermatophytosis is tinea barbi or tinea psychosis. This is called also barber's itch because you might catch it from the barber. This is the beard ringworm. Here we see this, of course, in adolescent males and in adult males, those who are bearded. And here we have infection of the hair of the beard. So the hair and the hair follicles are invaded by the fungus. It might manifest um, uh, as rather superficial. It might go a little bit deeper. It might be circinate, as you can see here. And if the hair follicle is invaded, so the hair follicle might be invaded because that would still be protective of the organism. It would protective of it from the serum inhibitory factor. So if this happens, if there is invasion of the hair follicle, you might see a pustule or an abscess. And the tinea barbi is mostly caused by zoophilic and anthropophilic dermatophytes. It's not very common, and after the infection resolves, depending on how severe it was and how it was controlled, you might end up with permanent alopecia after the infection resolves. So alopecia means the loss of hair. So you might permanently lose the hair depending on how well this is taken care of. So this is rather infrequent. The alopecia is infrequent. The permanent alopecia is infrequent, but it really depends on how well the infection is taken care of. Tinea capitis or the scalp ringworm. This is a type of dermatophytosis that is actually with an incidence that is on the rise. Here we have infection of the scalp, eyebrows, and eyelashes, and the hair shaft and follicles are usually invaded. Usually it starts out as a small papule, and then this papule will become pale, it becomes scaly, and it will spread in the ring form, in the circinate form. Lesions might be multiple, and they might merge together and coalesce. We don't have that much itching, so it's not too bad in terms of itching, but it might become intense occasionally. We usually have hair loss in the area that is affected. It doesn't have to be permanent, and we'll talk about when this is more severe and when it might be permanent. So the inflammation is variable. It's more common in children, and as I said, this is something that is on the rise and we have to watch out for. And now a little bit about the anatomy of the hair. So because we will be using these terms, so the cuticle is the outermost layer, and then we have the cortex and the medulla. And depending on how deep the invasion goes, we have what we call the ectotrix invasion, or we also have the endotrix invasion and favus. So we'll be talking about these different types of invasions or different types of uh, um, tinea capitis. Starting with the ectotrix type of tinea capitis. In this case, we have invasion of the hair cuticle, and if you're examining the hair shaft under the microscope, you'll see these arthrospores here on the exterior, and so the cuticle is destroyed. And because of this, the hair will break about 1 centimeter above the skin. The agents that cause this are mostly anthropophilic and zoophilic species of dermatophytes. As for endothelic invasion, as the name might apply to you, so this is a deeper invasion of the hair shaft. So what you see are arthrospores within the hair shaft. So the cuticle is left spared, nothing happens to the cuticle. So you'll see arthrospores within the hair shaft. This is almost exclusively caused by the anthropophilic trichophyton species. This is what the alopecia might look like, but there are some variabilities in what the alopecia presents as. So there's a type of endothelic infection called the black dot tinea capitis. In this case, what happens is that the fragility of the hair leads to breakage right at the scalp level. And so it looks as if this has been shaved. And you'll see the alopecia with black dots within it. And so this black dotted appearance, this is what led to the naming of this type of infection as black dot tinea capitis. It is a type of endothelic invasion. As for favus or tinea favosa, this is caused by an agent that is trichophyton schoenlinii. And so this agent is um, an anthropophilic agent. This is a specific type of endothelic infection. Instead of seeing arthrospores, though, within the hair shaft, what you see are these channels, these hyphae, actually. So these channels are hyphae. They are seen within the hair shaft. Um, this type of infection, tinea favosa or favus, it's characterized by these crusts, these cup-shaped crusts. These are yellowish crusts that we call scutula. So this term might resemble other terms that you'll hear today in this session, such as sclerotia or sclerotic bodies, which we'll talk about later on, but make sure you distinguish between these different terms. So scutula refers to these cup-shaped crusts. These are yellowish crusts. These are formed of the organism of the dermatophytes plus sloughed off epidermal layers or skin. And so you see these crusts. If you remove these crusts, we have a reddish moist base under them. And these crusts, believe it or not, I tried to pick a picture that was not very gross because these crusts might all coalesce together over somebody's scalp and you see one huge big crust. This is characterized usually by a very foul odor. It's a mousy odor that smells like mice. And this might result in permanent alopecia and scarring. It usually results in permanent alopecia and scarring after the infection resolves. As for carrion or carrion celsi, this is a specific manifestation of tinea capitis that happens due to invasion of subcutaneous tissues. So we've been saying so far that we don't usually see invasion. However, it might occur, and if it does happen, it happens usually by zoophilic and geophilic species, not anthropophilic species. And so if invasion happens, you might see this kind of manifestation. We have a reddish area that is inflamed, it's tender, and it has the sticky exudate coming out. This sticky exudate is referred to as carrion. And if this resolves, after it resolves, it usually results in permanent loss of hair and permanent alopecia. Tinea unguium or the nail ringworm. This is a dermatophytic onychomycosis. So what do I mean by this? An onychomycosis means a nail infection caused by a fungus. If it's specifically caused by dermatophytes, we call this Tinea unguium. So Tinea unguium is the term itself is reserved for onychomycosis caused by a dermatophyte because there are other types of fungal agents that can cause uh, infection of the nail. There are some bacterial agents that can cause nail infections. If it's a fungal agent, we call it onychomycosis. If it's specifically a dermatophyte that is causing the onychomycosis, we call this Tinea unguium. And this is a quite common type of infection in the population. Um, and the most common agents to cause this are the dermatophytes. More commonly, you see the toenails are affected rather than the fingernails. And you might see some nails that are not affected when the infection happens, but all 10 nails might be affected. It really depends on how the spread happens and if the infection was spread from one nail to another. There are different types of presentations, different types of severities, depending on the agent that's causing the disease, depending on how the infection started, and if the infection is treated appropriately or not. And so the infection might start distally here at the hyponychium. It might start proximally at the nail fold, and sometimes we might have invasion of the nail plate. And I have a couple of pictures on the next slide that might illustrate how the disease could progress and what it might look like depending on where the infection started and whether it was appropriately treated or not. If tinea angioma occurs, you might see hyperkeratosis, which means thickening of the nail. This is hyperkeratosis and discoloration, for example, in this case here. So onycholysis might occur where the nail plate will separate from the nail bed. The discoloration that you're seeing, for example, here is quite frequent in the population. And you might have a secondary infection if you do not really take care of the fungal infection. And so that would exacerbate the disease. And if you do not really control the infection, you might end up with a complete loss of the nail. So what you're seeing here is somebody who had a distal infection. Both of these cases are distal infections because they start out distally. And you can see that they are progressing inwards. There's somebody who has left that infection uncontrolled for a good long period of time, apparently. And you can tell that not all of the nails have the infection, so this one is spared here. So it's not really uncommon to see some nails spared. So the spread didn't happen to this nail, for example. As for what you're seeing here, this is a superficial nail plate infection. And so the infection didn't start proximally, it didn't start distally. This is a superficial infection. The itch reaction is not exclusive to dermatophytes. It can be caused by other infectious agents. However, when it's caused by dermatophytes, we call this dermatophytid. So this is auto-eczematization, and what happens here is that you see sterile itchy vesicles that appear somewhere on the body, usually on the hands, most commonly on the hands, but they might appear elsewhere, such as the chest and the arms. So these vesicles, they itch, but they are sterile. They do not contain the infectious agents. So this reaction happens in about 5% of ringworm infections. Itch reactions usually happen somewhere on the body that is distal to the area of infection itself. So we think what's happening is some intense inflammatory reaction happening somewhere because of an infection. And distal to that infection somewhere else, you will see the itch reaction happening, which is these vesicles. We do not understand the underlying basis of the itch reaction, and it is thought to be immunologically mediated. Uh, but what exactly underlies this immunologically mediated process is not very well known. Now, since the itch reaction is happening somewhere on the body, distal to the infection, due to the infection or the inflammation itself, the itch reaction or these itchy vesicles, they will disappear, they will go away if you treat the ringworm infection. The treatment of a dermatophytic infection relies on the type of lesion or the type of infection that you have. So for tinea corporis, people apply topical agents for 1 to 6 weeks, and that's usually sufficient. However, if you have more extensive lesions, or if you have numerous lesions, then you might need systemic agents, and these are given 1 to 4 weeks. You'll learn much more about these agents later on in the course. As for tinea barbi, you can apply topical agents, you can shave as well the infected area, but you need systemic oral therapy, and these agents are given then for 1 to 6 weeks. As for tinea capitis, which is mostly the scalp hair infection, we cannot really rely on topical agents. These are ineffective. And depending on the agents that you're using, the treatment can extend somewhere from 1 to 8 weeks, depending on the agent that you're giving and the extent to which the infection is affecting the patient. As for the nail infections, these are likely the most difficult ones to treat. You'll see that it's prolonged treatment. And so, despite treatment, we have a high recurrence rate. You need oral therapy uh, for 1 to 2 years. If you have a toenail infection, these are the most difficult to treat. It takes years, as you can tell. As for fingernail infections, they might respond within 3 months. But again, with nail infections, these have a high recurrence. The diagnosis will rely on the clinical presentation and on the wet mount and culture. And that's because the various types of dermatophytes, these are mostly filamentous molds, these are filamentous molds, and so they have various characteristics depending on the species. So people do rely on microscopic examination to figure out the types of dermatophytes or the type of species or genus they are dealing with, based on microscopic examination of the wet mount from the scrapings or from culture. And in the last section now, we will examine the various types of subcutaneous fungal infections. Subcutaneous fungal infections are caused by agents that are saprophytes. They are environmental agents. They're present on plants, on moss, on wood splinters, as you'll see. So for us to get infected with these agents, we need some traumatic inoculation that will lodge them into the dermal layer or the hypodermis, and then we would get subcutaneous mycosis. So they do not really spread systemically unless the person is immunocompromised, then that is possible, but usually they do not spread systemically. They might affect the muscle and the bones, and that is a possibility. So in most cases, you'll see these are not painful types of infections. They take a prolonged period of time to appear, and they're not very painful. This is why people ignore them. They become painful if they do affect the bones, for example, of course. But for the most part, they are not painful. The various types of subcutaneous mycoses are sporotrichosis, chromoblastomycosis, and mycetoma, which can be caused by fungi or bacteria, and we'll be discussing these in this section. So these are environmental agents, as I mentioned earlier, and then we get them after traumatic inoculation and penetration of the skin. And so they become implanted into the dermis, into the hypodermis. They stay there. They do not disseminate unless somebody is immunocompromised. However, they might occasionally disseminate in somebody who is not immunocompromised. They might go to the bone and the muscle tissues. So usually these are not painful infections unless they actually do go deeper. They're mostly seen in tropical and subtropical areas. Starting with sporotrichosis, which is also called rose Gardner's disease, and rose thorn disease. And as you might surmise from these names, gardeners do get this disease because it is present on plants, present on rose thorns, and gardeners might get infected with this kind of agent. So after you have traumatic inoculation, after penetration of the skin, the infection could be asymptomatic. And then what happens more often is after about 3 months or less of the incubation period, what happens is you have possibly two forms of cutaneous disease. Now, cutaneous in the sense that it affects the skin. I don't want you guys to confuse this with the fact that we talked about dermatophytes as cutaneous mycosis because those were more confined to the cutaneous tissues. In this case, the skin is affected, but the infection affects subcutaneous tissues as well. So the cutaneous sporotrichosis is of two forms, the lymphocutaneous and the fixed cutaneous. The most common type of cutaneous sporotrichosis is lymphocutaneous or subcutaneous sporotrichosis. It happens in about 80% of cases. And here, what we have first at the site of inoculation is a pustule. It's painless, doesn't hurt, it looks like an insect bite. And then it ulcerates. So this pustule will ulcerate, and once ulceration happens, you start seeing spreading along the lymphatic pathways. And the lymphatic pathways, of course, have lymph nodes, and so you will see these nodular abscesses, which are actually the infected lymph nodes. These will then ulcerate and will drain, and you'll see what that looks like on the next slide. So the infection usually, in most cases, starts at the thumb and then starts spreading along the arm, but then will stop at the axilla region, at the armpit, that is. This is a chronic infection, so the progression is quite slow. So this is what lymphocutaneous porotrichosis looks like. Like we said, the infection usually happens, it starts at fingers. So in most cases it's the thumb, but in this person's case it was the index finger. And you see that starts spreading along. These are the nodular abscesses, which are the lymph nodes. And then what happens is, because this is not painful, so believe it or not, this is not painful, it might go uncontrolled and not treated. And what will happen if this is ignored is that eventually they will ulcerate, these nodes will ulcerate, and they will drain. Scarring might happen if this is not controlled and not appropriately treated, of course. As for fixed cutaneous porotrichosis, this usually happens in areas that are endemic to the agent of disease. And because of the endemicity, people have either been previously exposed to it or have had the lymphocutaneous form. So it happens in people who have been previously exposed to the agent. And here what you see is just a limited solitary nodule, so just one nodule that might ulcerate. It's less progressive, as you can tell based on the previous slide. And here we don't have invasion or affecting the lymphatic system. There are other forms of sporotrichosis, and bear in mind, some of them are not very common, and some of them are unusual. And this is actually the case with a lot of the agents that we are discussing today. Sometimes the presentation is um, different from what you expect, specifically with these subcutaneous agents. So let me give you an example. There was a guy who had sinusitis for about 12 years, and people couldn't figure out what the reason was. And it turned out that this person was harboring the agent of sporotrichosis, which, as you will see, is Sporothrix schenkii. And so this person had uh, sinusitis because of this. Now, there are slightly more common forms, such as osteoarticular sporotrichosis, which as you can tell from the name, this affects the joints, but might affect the bone as well. Pulmonary sporotrichosis, and here in this case, instead of having acquired the infection by traumatic inoculation of the skin, penetration of the skin, this is due to inhalation of the agent. Meningitis is rare and dissemination is not common. It happens in the immunosuppressed. And in this case, you spread the agent to various organ systems. So you have spreading of the agent via blood. So fungemia might happen, and various organ systems are affected. The causative agent of sporotrichosis is Sporothrix schenkii. This is a dimorphic fungus. Now, clinically, you can rely, of course, on the clinical presentation and the patient history. You will ask, of course, whether the person is a gardener, if they like spending time in the woods, if they like to pick roses. All of these can help you out in figuring out the type of infection that you're seeing. Because, well, lab diagnosis is not very easy because we have very few organisms in the samples that you might acquire. So for example, here, this is a histological section. Of course, you cannot rely on the wet mount. You'll have to do biopsy. So this is a histological section from a lesion, and this was stained with periodic acid Schiff, and what you're seeing here is PAS positive budding yeast-like cell in the infected tissues, and this is not very easy to catch under the microscope. Because we have very few organisms in the sample. You can rely on culture as well, but again, not too easy because of the scarcity of the presence of the agent in the samples. Usually, it requires multiple approaches to treat such an infection. So, oral agents might be useful for limited cases. You can also use intravenous systemic agents for more difficult cases. To improve the status of the lesions, you will need some type of thermal therapy or cryotherapy, surgery as well. And usually all of these approaches, they take a long time to work, so the treatment is usually prolonged, so about 3 months to 1 year. The second type of uh, subcutaneous fungal infection we'll be discussing is chromoblastomycosis or chromomycosis. And here again, just like with Sporothrix, this is an agent that's present out there in the environment, just like with all of these subcutaneous infections. So to get them, we need traumatic inoculation. Most commonly here is because of a wood splinter. And just like with all of these subcutaneous infections, the disease is very chronic, very slowly progressing, and so it takes a very long period of time. In most cases, the limbs are usually affected, again, because you have to think that this is the most easy area to have penetration by a wood splinter, for example. And what happens, it usually starts with a very painless wart-like nodule. So this takes a long time to appear. And so because of this, because it's painless and it takes a very long time to appear, a very long time to progress, this is why people might ignore it. And it can just stay there for a long period of time with a person unaware of this type of infection. So the infection is limited to the skin, it's limited to the subcutaneous tissues. And so it's not painful, doesn't hurt, and it takes a long period of time. Now, if it is uncontrolled, the person doesn't take care of it, if it goes unnoticed, and so it might progress into a more severe form, as you'll see on the next slide. And so, if that wart-like nodule is ignored, it will progress over a long time, over a period of years, and uh, this is somewhat a little bit more progressive, as you can tell, than the previous slide. Then, if it really goes uncontrolled, it might progress to affect the whole limb, which you're seeing here. This is the characteristic um, cauliflower or head of cauliflower. I told you I'll be reviewing several food items for you today in this lecture, or these two lectures. So this is the off-white scarring that is seen with chromoblastomycosis. If it affects the whole limb, if it's left uncontrolled, these lesions are varicose, they are crusted, and sometimes they ulcerate, and we have plaques and nodules over the limb. And now, believe it or not, the infection is mostly localized, although it might spread. You'll see how in a little bit on the next slide. In most cases, you only affect the limb, it stays localized there, and again, not too painful unless it spreads down to the bones, to the muscles as well. The lesions of chromoblastomycosis might be complicated by secondary bacterial infection, and so what you would have is a very bad smell that results because of this, and it often results in lymph stasis, which you're seeing here. So we have elephantiasis because of this. Now, the fungus, as I said, is mostly confined to the limb. However, we might see metastatic nodules at distal sites, mostly seen in somebody who is immunocompromised or whose immune system cannot control the infection very well. So for the most part, this is confined to one limb. It doesn't spread along, but it might happen in somebody whose immune system is not capable of coping with the infection. And if dissemination happens, of course, you might affect organ systems, and of course, you would have a more complicated type of infection. Now, rarely you might end up with squamous cell carcinoma because of this type of infection. The agents that cause chromoblastomycosis, they are a group of demataceous molds that include species that belong to the genera Cladosporium, Falcicia, and Fiolophora, in addition to more rarely by Rhinocladiella and Axophiella. Now, all these can produce the pathognomonic sclerotic bodies. So pathognomonic, this is a defining characteristic that is of chromoblastomycosis. The sclerotic bodies, watch out, I'm saying sclerotic, I'm not saying scutula, which you saw earlier, or sclerotia, which we'll see later in the lecture. So the sclerotic bodies, these are also called copper penny bodies. So if you take a look at them here, they do look like copper pennies. These are not yeast cells, as you might expect. These are molds. So the species that cause chromoblastomycosis are molds. And so these are actually hyphae-like elements with cross walls. So these are cross walls. They are not yeast, and they are a defining characteristic of chromoblastomycosis. So diagnosis relies, of course, on the clinical presentation. You can also do the wet mount, and you'll see these sclerotic bodies and hyphae. Histology can be performed as well as culture. As for treatment, similar to the other subcutaneous mycoses, all of these require multi-management approaches. And so chromoblastomycosis is difficult to treat and will not respond very well. It might last, the treatment that is might last weeks to years. And so you'd use oral or IV agents, cryosurgery, surgery, thermal therapy, or cryotherapy. And so multiple types of approaches are required, and still treatment will be difficult. The last type of subcutaneous fungal infection we will discuss today is mycetoma or Madura foot. Madura is a region in India where the disease was first described in the 1800s. Most commonly, it affects the feet, so it happens in 70% of cases. It might also affect the hands. And again, just like with the others, it's a very slow disease. It requires traumatic inoculation for the skin to be penetrated, and so the inflammation, it's chronic, it's very slowly progressive. The incubation period is long. So all of these characteristics apply to all of these subcutaneous infections that we're discussing today. And what we have here is an infection of the skin and subcutaneous tissues. And believe it or not, again, this is not too painful and might be left ignored. It becomes painful if it goes deeper. So occasionally it might spread to the muscle and the bones, and so you might have some pain in that case. Now, this is characterized by three characteristic symptoms. First, tumefaction, which means swelling of the limb. We have draining sinuses, and we have this exudate that comes out of these sinuses. And the exudate will contain granules that we call sclerotia. So again, this is usually not painful unless it spreads a little bit deeper to the bone. But if you have, or the muscles, and if you have a secondary bacterial infection, um, then yes, of course, pain might happen and that might exacerbate the case. Mycetomas can be caused by fungal agents as well as by bacterial agents. If it's caused by a fungal agent, this is called a eumycetoma with the affix U referring to true, so it's a true mycetoma. Now, species that can cause this mostly belong to the genera Madurella, Pseudolicheria, and Leptosphaeria. However, there are species of other genera that can also cause this. There's a long list, as you can tell. Some of these are quite relevant to us because you'll see them with other infections, other types of infections, such as Aspergillus, which you'll see as an important cause of systemic fungal infections, Fusarium, which can cause opportunistic infections, as well as nail infections. And then we have Exophiala and Fiolephora, and we saw these with chromoblastomycosis. If the infection is caused by a bacterial agent, usually by bacterial actinomycetes, this is called actinomycetoma, and most commonly it's caused by nocardia. Now, mind you, there are references that mistakenly call this actinomycosis. Actinomycosis is different. It's caused by certain actinomyces, and so here we're referring to actinomycetomas that are caused by actinomycetes. Alright, so if it's a bacterial agent, then if you take the granule, the sclerotia, and you crush it, you'll see very thin filaments. The actinomycetes are filamentous, and you'll see filaments. But these are thin filaments. They are less than 1 micrometer in diameter. However, if it's a fungal agent, then the hyphae are larger. They're more than 2.5 micrometers in diameter, and so you'll see a wider hyphae. Of course, it takes a trained, skilled eye under the microscope to figure out what kind of agent we're dealing with, and it's important to figure out if it's a bacterial or a fungal agent, and you'll see why in a little bit, but of course, as you may guess, it's because of the treatment approach that you will take. How is a mycetoma diagnosed? Of course, clinically, based on the clinical signs. Um, And in addition to that, you can take the sclerotia, crush them, examine them under the microscope, and try to figure out if it's a fungal agent or a bacterial agent. And of course, this can be supported by culture. You can tell if it's a bacterium or if it's a fungal agent. You can also do tissue biopsies and do histological stains to try and figure out what is happening. Now, if it's an actinomycetoma caused by bacterial agent, this is better news for the patient because although the treatment is prolonged, bacterial agents usually respond to combinations of antibacterial agents. So actinomycetomas are more responsive to treatment than the eumycetomas, which are more difficult to treat, and they require multiple approaches to treatment. You can use systemic treatment. In this case, it is prolonged, might be up to 1 year. In addition to that, this can be complemented by surgery, and it depends on the severity of the situation. So this could range from partial to amputation. Um, so again, eumycetoma is much more difficult to treat than actinomycetomas are. We will conclude these two lectures with the following question. So what do you think is happening with the picture here? Is this somebody who has A, an ectotrics tinea capitis, B, an infection with epidermophyton, C, an infection with trichosporin, or is this somebody who we are exposing to UV light at 36 nanometers wavelength? So if you've answered A, ectotrics tinea capitis, this is of course incorrect because we cannot tell whether this is ectotrics or endotrics just based on the picture. You would need a microscope. Now we can tell this is alopecia and this is something fluorescing here, but we cannot tell whether it's ectotrics or endotrics without examining the infection under the microscope. Somebody who's infected with an epidermophyton species, well, they do not really cause hair infections. On the other hand, we cannot really tell the species just by looking at the picture. Infected with well, they do not really cause alopecia. They cause those species, they cause hair nodules, white or off-white hair nodules, which we're not really seeing here. D, and this is the correct answer, this is somebody you're exposing to Wood's light at 366 nanometers of wavelength, resulting in fluorescence of the alopecia or the infected area. Now, this will conclude our lectures together. And I'll remind you, if you have any questions, please email me at er00@aub.edu.lb. And thank you for listening to these lectures.